Doctor. Over to you, Dr. Abid. Yeah.
Okay, thank you. Okay, hello, good afternoon, everyone. First of all, we would like to apologize for our technical glitch just now, and I hope that most of you have managed to come back into the webinar link. So, on behalf of AOEMM, I'd like to thank all of you for taking time off to attend this webinar. And we are very fortunate to have with us Dr. Hazlee Abdul Hadi, who is a very experienced occupational health practitioner, and one of his interests is in underwater medicine. So, since this is a very sort of unusual specialty or interest, we thought that it would be interesting to let us, all of us here, to really appreciate the intricacies of all underwater medicine. And towards this end, I do not want to, say any more than that, because Dr. Hazlee has got lots to tell us about what underwater medicine is all about. So over to you, Dr. Hazlee. Oh, by the way, before I go on, just to remind all of us to mute our phones while listening to the presentation. Number one. Number two, questions and answers. Can you please type in your questions on the message board, and then we will sort it out at the end of the presentation. Don't worry, this session will be recorded, and you can access this later on if you've missed parts of it. Yeah. Okay, thank you very much, Dr. Hazlee. Over to you.
All right, okay. I'm trying to share my screens now. I think, Sherry, can you share the screen because I couldn't do it on my end.
Okay, Doktor tak dapat buat
Oh, so couldn't,
You want me to
nothing appear in.
Nothing appear there. Okay, you want me? It's
Yes.
okay. It's now. You are sharing the screen now. Maybe you can go to your presentation. Try again.
Select from only if you click the screen.
It's
Still
okay.
nothing in my screen.
See nothing.
I can choose. Yeah.
Okay.
Maybe Sherry take over lah. Share the screen and Doctor maybe sebut next. Then we can proceed. Yeah.
Boleh. So I'll proceed with sharing the screen, Dr. Hazlee. Okay.
Okay, full screen, please, Sherry. Is that okay, everyone? You can see the slide?
That looks good.
Yeah.
That
Yeah.
looks good. Yes.
All right. Thank you, Dr. Abid. Thank you, Jessima. Thank you, Sherry, AEM. All right. So we go into overview of underwater medicine. So for your info, I did my underwater medicine training in Singapore. That was many years ago, under Navy as well as SGH, Singapore GH Hospital. So I did practice until now, basically. Still practice underwater medicine. I still do diving, commercial, mostly commercial. Leisure, they do come to me, but in Malaysia, there's no regulation for people to go on leisure diving to go and see underwater medicine. But for company, usually they need to see underwater practitioner to carry out their medicals. All right, okay, Sherry, next. Can you move the slide to second one? All right, okay, so there'll be introduction, unique stressor, decompression sickness, going to talk about nitrogen narcosis, how it happened, barotrauma treatment for underwater medicine, medical assessment is what I do quite a lot, as well as safety training for the divers. Next, sorry. So underwater medicine, as mentioned by Zabit, is a specialized field of clinical practice. It is not covered in our medical school, I suppose, so much. we do the physics, which I'm going to mention in short. But anyway, it's a field regarding safety, medical, underwater environment. So it could be recreation, like you mentioned, but for us, we're going to concentrate on occupational, military, commercial, as well as for scientific purposes. Next, Sherry. Can you move to the next one, Sherry? Sorry. So if you look at this photo, underwater logging and people doing welding underwater, and it's at the base of, can be imagine how far it could be. Usually 30-meter deep is already deep. This one probably going more than 30 meter, 40, 50. Some I heard of people going even more than 80 meter depth for diving. Of course, piping and underwater work to establish offshore platform and whatnot. Next, Sherry. All right. So this photo, I think, will tell us if it's going to be on land. I think it's quite easy. I mean, not so easy, but imagine doing this underwater. So as big as this person, if you take a human doing it on land, probably take few hours. But underwater, at the base of, it may take few hours for the whole work to complete. And imagine the pressure that is being endured on the person as well as whoever working on this, going to be an physiologically, physically, as well as emotion, as well as mentally for this person. We'll talk about that in a short while. Next, Sherry. Okay, research as well. Some do it for research, looking at the underwater living creatures can be at the base of. It's beautiful, but there's also a lot of stressor underwater. Next, Sherry. All right, okay. So the first one is the unique physiology. As the photo is showed on the right side, at 0 meter, which is 1 atmosphere pressure, the balloon at 100% size. But if you go deeper, every 10 meter, there will be another 1 atm atmosphere pressure. And as we go along another 10 meter, at 40, only 1/5 of the size of the original balloon. So as that diver descends, the ambient pressure increases nearly by approximately 1 atm for every 10 meters of seawater. I think that's what we learn, physiology. Okay, next, Sherry. Okay, with increased pressure, then there will be increase in partial pressure of the gases that rise. So we know that our inhaled of gases naturally is nitrogen 7% and oxygen about 21%. So nitrogen with 10% with increased pressure, there will be a lot more of pressure on nitrogen going into the tissue or going into spaces in our body, or divers is going into the sea. So elevated or partial pressure oxygen can cause oxygen toxicity, and elevated of nitrogen can cause nitrogen narcosis. We're going to talk about shortly. Next, Sherry. So with increased pressure, there will be increased density of inhaled gases because it's already been compressed. So it will increase the work of breathing, so during exertion or in depth, and also can cause hypercapnia, increase in CO2 level, and can also cause hypoxia, decrease in O2 because of hemoglobin attachment to CO2 a lot more under pressure. So if the diver unable to compensate adequately, then it's going to cause consequences of medical issues while diving underwater. Next, Sherry. So we have talked about partial pressure, and now the actual pressure itself, increased hydrostatic pressure on the diver. So external pressure compress the body, and we also know that in our body there's compressible spaces as well as non-compressible tissue. So compressible spaces would be like lung or middle ear, sinuses, or imagine if there's pressure on the lungs itself, so the lungs can collapse, can compress, and non-compressible can cause experience external pressure. We can alter the blood flow and gas solubility as well. So the actual pressure, partial pressure, all can cause physiological changes as well as pressure on the person, physically as well as mental. Next, Sherry. So in this one, basically talking about increased pressure and solubility. We talk about 79% is nitrogen and 21% is oxygen. With high pressure, what happens is that gas soluble, increased ambient pressure lead to significantly increased amount of inlet gas, primarily nitrogen because 79% dissolving into the diverse body tissue. This is the crux of it. I think we'll talk about it later because the gas, the balloon size, as we mentioned just now, balloon size from 0 can go to 1.5 when it goes to above 50-meter depth of seawater. Next, Sherry. So this is just the physics, and then we talk about the physical, right? Temperature itself. Imagine we are in the cold, cold weather. We start to feel it on land. Imagine doing it underwater, even though it's warm, because water conducts heat away from body approximately 25 times faster than air. So even though it's warm water, can lead to hypothermia, can impact cognitive function, motor skill. You can be shivering, can be not in good shape, and that will increase the risk of DCS. So cold water itself can trigger bradycardia as well as vasoconstriction. So physiological changes can happen due to the temperature difference, which is normally due to it being cold underwater. Next, Sherry. And again, visibility. Whoever used to dive, if it's dive deep enough, what happens is that everywhere looks the same. So you can have limited visibility, murky waters, suspended particle, algae, bloom, sediments, and can cause disorientation, spatial disorientation, and panic anxiety. That's why training is very important. So those who are under training, they probably have good guidance from whoever their mentor, and probably going to give them a good technique. Or can use your barometer, can use your watch, dive computer that can use for you to guide on where you are, how deep you are, and what sort of control you should be taking when you are at the depth, certain depths of diving. Next, Sherry. So another one is, of course, we can't communicate as per normal. Usually this is from PADI communication challenges where we rely on hand signals. So if you look at on the photo, it's not that big, but you can see there's both breeze, danger, hazard, I'm in distress, and all and so on. So all this for those who are experienced, okay, they know what that means. But for newcomers, new joiner, they may not be able to use the right signal, and especially when they are in panic situation, they will just basically leave everything, start to ascend as soon as possible. That can cause decompression too quickly and cause damage to the organs if there is blockage due to air bubbles coming out from their system, either from blood vessel or from their tissue. So the hand signal is there, but not people are okay to use it or can use it properly when they are in panic situation. Next, Sherry. So psychological stress is another one. For experienced one, I've been seeing experienced one has been doing for 20, 30 years. I think this is like second nature to them. They know what to do. They know what's anxiety. They know what's abnormal. They know how to handle untoward circumstances. But for newcomer, they could be feeling of confinement, self-contained breathing apparatus, equipment malfunction could be there, and the risk that could be there. And if they go into panic, they go into anxiety, then it will impact the decision making, physiological, and they start to be rapid breathing, increase CO2, and most of the time they'll try to go to the surface as soon as possible. Next, Ray. So case one, this is how physiological can affect. Relatively inexperienced recreational driver descend to 30 meters, which is 4 atmosphere pressure in a cold murky water with marginal buoyancy control. The increased gas density make it breathing feel labored as mentioned previously, and there is cold hypothermia begin to set in despite the wetsuit, and limited visibility, cause of disorientation leading to mild anxiety and rapid breathing. Combination of all, increased work of breathing, potential hypopnea, psychological stress significantly increases susceptibility to most barotrauma because it's ascend too fast, too quickly without stopping, over expansion of injury if it's ascend without exhaling, and decompression sickness. So this is a simple case of how this can happen, especially for those not very experienced diver doing it the first time without guidance, without buddy, do it on their own. They can end up with complication of diving, lung overexpansion and DCS as well, decompression sickness. Next, Sherry.
Sherry, can we move to the next slide?
Sherry, can you move? All right, okay. So again, we're looking at the right photo. Decompression sickness basically is the other one from normal bubble in our body on land. When you go deeper, it becomes smaller. If you go too fast, what happens is that it will just expand beyond the capability of equilibration. So it potentially serious depending where it is, life-threatening, and is cause of formation of gas, primarily nitrogen, within the tissue and bloodstream of diver after they ascend from a dive too fast without looking at the time where they need to stop. We call it diver stops, maybe a few minutes and let them exhale and there will be equilibration. But if it's too fast, there are cases they're going to show shortly where people do end up with complication due to decompression sickness. Next, Sherry. Sherry, next one.
Sherry's slide is not moving. Sherry, can you move to the next one? Sherry? Sherry?
How about now? Is it moving?
Not moving. No, it's not.
Not moving. Okay. Is it okay, Doctor, right now?
No.
No, still the same.
Oh, still
No.
same.
I see. Okay. Let me try reshare again, yeah.
Okay, next one. Okay, so basically with DCS, there could be mechanical obstruction. Prior to that, Sherry. So it depends on where it is. I think there's a slide prior to that. Oh, so never mind. So what happens is that if the oxygen can be nitrogen and oxygen dissolve too quickly, prior there's another one before that. One more, I think, prior to that. Okay. This is very important because we need to understand from the law, Henry's law, the inert gas basically dissolve in tissue, but when you go up too quickly, the dissolved gas comes out and forming bubble. It can be intravascular within blood vessel or extravascular. Next one, Sherry. Sorry. So what happens is that with that bubble is too big and we cannot equilibrate good enough It can cause mechanical obstruction. Can be in the spinal, can be in the brain, can be in the lung, can cause pulmonary DCS, cerebral DCS, and because of that bubble into our organs more than it should, it can also create inflammatory response as well. Vascular permeability, cause edema as well, inflammation, and cause tissue damage as well, of course. And because of that, that can also cause platelet activation as well as coagulation. So the whole bit is the decompression sickness itself. Boleh Syari, next one. Next one, Syari. Intravascular, yes. Mechanical obstruction covered, can cause inflammation, can cause tissue damage as well as macrothrombi. Okay. So the manifestation is that it depends, highly variable. It depends on location as well as size of the bubble, and typically occur within hours of surfacing, can occur immediately or even days later. But I've not seen anything more than 7 days, usually about a day, 2 or 3 days after the dive. And clinical manifestation is quite clear because that person going for a dive and then they either travel on air using flight too quickly and can cause this DCS. Next, Sherry. Boleh, Sherry. Next one. All right, okay. So the clinical manifestation can be either type 1, you call it mild 1, or serious DCS, which is type 2. So type 1 usually mild ache, mild rashes, tissue tenderness, mild constitutional illness, and type 2 will be more severe than type 1. Can cause confusion as well, vertigo, chest pain, bladder, bowel dysfunction, tinnitus, or even can cause severe neurological damage to that person as well. So type 1, as mentioned, mild pain, skin manifestation, and type 2, next one, Sherry. So we'll look at photo of type 1 first, if there's any. Sherry, next one. All right. So from this, the person is still okay, but you can see there's mottling of the skin of that person, and also mask squeeze on the face mask of their SCBA, self-breathing apparatus for that person. And next, Sherry, next one. Next slide, the photo just now. Okay, next one is type 2, where it's more severe. Can have spinal DCS, paresthesia, weakness, progressing down the spine, or can have also cerebral fat embolism. This in the brain. Can mimic cerebral DCS, decompression sickness, and usually occur within minutes of surfacing or after pulmonary barotrauma. Okay, next one, sorry. Next one is not so common. This is in the lungs pulmonary where this choke type 2 DCS, type 2 of decompression sickness is rare but life-threatening. So any case to do with pulmonary, brain or type 2 basically, all of them need to be going into HPOT, the hyperbaric oxygen therapy, where we compress and get it to smaller size, and we want the bubble to go back into the stream, and we release it slowly, basically going up again. We simulate that person going ascend the depths of the diving slowly so that the bubbles can go into equilibration and the person can go back to normal. So require immediate recompression for any of type 2 basically. Next, Sherry. So we're going to risk factor, next one, Sherry. So all divers by right, they should have their tables on how deep they should go, how long they should be at that depth, and how long it should take for them to come back to the surface.
Sherry, can you move to the next slide, please? We are not able to view the next slide. Yeah.
Right, Sherry. the risk factor for DCS.
Sherry, your slide is not moving. Yeah.
Risk factor for DCS, right?
The next one.
Yeah.
After this one is the risk factor.
Yeah, this is risk factor.
No,
No,
we are
meaning
no, it's
seeing
not.
clinical manifestation, Sherry.
Okay,
Mm.
okay.
Data link. Okay, so risk factor basically exceeding the non-compression limit. Previous one, Sherry, I think you go too fast now. Okay, right. So making too fast of an ascent, this is very important. That's why for everybody is going to dive deep enough, they should have their timetable on how long going to be at the depth and how slow or how fast they should go up. Really not too fast. You probably have your break in between before you get to the surface. And flying too soon after the dive and dehydration also risk factor, fatigue, and then you do too many dives, in short period, exertion during the ascent, you're just too tired, and you start to basically not following the timetable that you should be following. Obesity, again, higher nitrogen loading, higher fat would have a lot more nitrogen. So with higher pressure of nitrogen, there's a lot more of bubbles come up from the intravascular as well as extravascular. Older diver, I diver due to physiological changes, history of previous DCS, and certain medical condition, as you know, pattern, foramen Everell, because there's a pathway basically, bubble bypass the lung and enter the systemic circulation. And as mentioned, repetitive diving in a short period. Next one, Sherry. So for this, basically diagnosis, I think quite clear. Like I said, in most cases, I'm running diving clinic. So people who come here, most of them are diver if they have any issue. And I also got referrals within KL if there's any issue, a mild one. Of course, severe one, I would want them to be from the phone. I would just send them to the nearest HBOT clinic nearby their places, a hospital or any clinics that have HBOT, the chamber for recompression. So primary clinical based on the history of dive and the onset of characteristic. Physical examination may reveal specific sign, joint tenderness, skin working as shown just now, neurological deficit. And if the hospital referral, you can do MRI for neurological DCS and to rule out any other pathology. Doppler ultrasound is useful, but not always necessary for management. So diver DCS2 usually decompression as soon as possible rather than waiting for all the result. Doppler may not be necessary. And ruling out other differential diagnosis as mentioned, stroke, spinal cord injury, myocardial infarction, hypoglycemia, and inner ear. I think by that time, if you do have labs in the hospital, they will run all the necessary to rule out all other diagnoses as well. Next one, Sri. I'll just go fast a bit on the nitrogen narcosis. It's, as mentioned, 7% in our air is basically nitrogen. And because of that percentage, it's very likely for nitrogen to be in the tissue as well as in the blood in terms of bubbles. And we do ascend fast enough, and nitrogen can become a bubble. And they also can cause narcosis, which is a feeling of drunkenness and euphoria because of partial pressure. Increased partial pressure can cause a lot more nitrogen get into our blood as well as our extravascular as well as intravascular. And this usually happen if we go deeper than 30 meters. So for those of you doing leisure, anything to do with 10, I think 15, 20 should be safe. Anything to do to go more than 30 meters can risk of a person getting nitrogen narcosis, especially for the new divers. Next one, Sri. Okay, from a scientific point of view, it's not well understood why it causes nitrogen narcosis, but could be due to interaction of nitrogen with the lipid-rich component. Like I said, it's a reversible alteration. Next one. And it probably disrupt normal neural function because of their concentration. It's a lot more as compared to what we normally have on land, where we have 7%, but the pressure is not that high enough to cause the narcosis. But in terms of clinical manifestation, it's like drunkenness, euphoria, giddiness, impaired judgment, and can cause slow reaction time. Next one, Sherry. Right. So again, because of judgment, impaired coordination, impaired fine motor skill, loss of concentration, can cause anxiety, panic, auditory changes, and in severe cases, at high pressure, symptoms can progress to hallucination. I have not seen one, and severe disorientation as well as unconsciousness. But next one, sorry. It is actually quite easy to reverse if we can recognize it from the start. So how do you prevent ascent to shallower depth? So according to your depth now, say going 50, slowly going to 45, 40, partial pressure of nitrogen going to be lower, and then you will can reverse this nitrogen narcosis. So diver should train to recognize and using breathing gases which is lower concentration, lower percentage of nitrogen, nitrox, E, A, and X, and technical other gases, trimix or heliox, that can be used with lower concentration of nitrogen, and of course training as well. Next one, Sherry. So we go into an example of how we can basically reverse this. A technical diver descend to 45, like I mentioned, anything to do with 30 and less, if we go on Malaysia, I think should be okay. But above 40 is considered deep dive already. So that is close to 580A. So his descent, he begin to feel a sense of well-being and harder to concentrate. His body, okay, again, body system is very important. If you go dive, usually for commercial, it's a must for you to go on body system. So in this case, there's a body. I noticed that he becomes slightly uncoordinated, seem less aware of the surrounding. And recognizing the sign and significant nitrogen narcosis, the team decided to turn the dive early, go up ascent as per schedule, begin a controlled ascent, and diver coordination connectivity basically improve rapidly and confirm the diagnosis of nitrogen narcosis. So it's quite easy to reverse if we recognize. If you don't recognize, you go deeper, spend a lot more time, so you have a lot more nitrogen in the system. Basically, although it's unknown, it could be due to a lot more nitrogen start to disturb our normal physiology. Next one, Sherry. So we move on to barotrauma. As mentioned, the pressure difference can cause the barotrauma, pressure different, gas twist, some gas fill, some are not. So that can cause the problem. Next one, sorry. Okay, barotrauma, as mentioned, gas filled space within the body, and there's a round ambient pressure which is changing because of the dive and pressure due to the ATA difference every 10 meter. So during descent, the external pressure increase. This one is from earlier slide that I showed, compressing the gas spaces. And the pressure difference can cause implosion if it go in. As example, in middle ear or squeeze, or during ascent, what happen? It will go out, so it can cause explosion. So overexpansion can cause tissue rupture or damage. This is pulmonary. Example given, pulmonary barotrauma. So implosion as well as overexpansion of the spaces in our body. Next one, sorry. So barotrauma, again, it depends on the location. The most common is middle ear barotrauma, not so dangerous. It is quite clear the person would know there's something wrong. The drum is forced inward and potentially causing pain, hearing loss, dizziness, and even perforation or bleeding behind the drum. Next one. So middle ear. Next one, Sharif. So sinus barotrauma, similarly, because of the air space when the sinus passages being blocked and can cause pain in the affected sinus, potentially leading to bleeding or mucosal damage. Next one. So MEB, middle ear is very common, sinus is very common. This pulmonary, is a big space, not so common, but can lead to life-threatening condition occurring during ascent if the diver basically hold. During our ascent, basically during the stop, we need to basically inhale, exhale, and for us to achieve equilibrium. But if the diver hold, just imagine holding and the airspace is getting bigger too rapidly, and the expanding gas in the lung can rupture the alveolus and can lead to pneumothorax, where the air can enter the pleural space and collapsing the lung. So during the training, we tell this, during the stop, you need to inhale, exhale, and try to achieve equilibrium so that the expansion is not as bad, and we can achieve equilibrium and there's no damage to the particular organ. It can be the MAB, middle ear, sinusitis, or even the our pulmonary, our lungs. Next one, Sherry. Okay, so this one also not uncommon, where the air basically entering mediastinal area around the heart, major blood, can cause subcutaneous emphysema if it track upward into the neck and chest wall, and can cause pneumoperitoneum as well. So one is around the heart mediastinum, another one is pneumoperitoneum, where air entering the abdominal cavity. Next one. All right, so this is serious. We talk about middle ear. This one is inner ear, close to our brain. Very serious, and often debilitating injury can occur during ascent due to direct trauma to the inner ear from violent equalization attempt, or MEB, the middle ear with round window rupture, and can cause further damage to inner ear, or ascent due to barotrauma as well as overexpansion. So barotrauma itself can cause inward as well as explosion. So this one basically overexpansion and can cause damage to our inner ear. This is very serious. So the person with inner ear trauma need to be in the chamber as soon as possible and given oxygen as soon as possible as well. Next one, Sherry. So as mentioned, this is a severe one. It's not just in the ear, it starts to affect our balancing, vertigo, nausea, vomiting, and if it's severe bleeding, can cause all of that. Hearing, tinnitus, sometimes facial nerve paralysis, require urgent evaluation, and as soon as possible need to be transferred to hyperbaric chamber as soon as we have the chance to transfer this person to next medical facility with HBOT. Next one. I think more serious one, cage. We have quite a few cases where cage is not being treated and end up with death. So air bubble basically start to enter the pulmonary capillaries. Air bubbles rupture the pulmonary vein and travel to systemic circulation, typically lodging in the brain or in the heart. So in the brain, basically cage, cerebral AGE, or in the heart can cause heart attack. So symptom basically sudden onset of neurological deficit, can cause chest pain, shortness of breath, and even loss of consciousness. That's why it's very serious. Medical emergency needs to be recompressed as soon as possible. Next one, Sherry. So this is our deputy minister many years ago. Basically, he was in Melbourne, Australia, do a bit of diving, but unfortunately, not his job, but going there for leisure, going probably more than 30 meters during that time, and without proper guidance or supervising him to dive, and he went up too quickly, whether due to anxiety, panic, or whatnot. He went up too early, and there's bubble formation in the brain, and basically he died due to CAGE, cerebral atrial gas embolism. So this is the one cases that training is very important, body system very important, and supervisor, and basically dive table that we need to follow as whoever going for dive commercial or even recreational. If it's deep enough, need to have all that checked before we start with our dive, and making sure we follow the diving protocol. If we do want to dive, how long going to be at the bottom and at what depth, and how long we need to stop in between before we get to the surface. And next one, Sherry. So I think I will stop here with a bit of training. Proper diver training is important during descent as well as ascent. Adequate surface interval, avoiding breath holding during ascent are very critical. So all this come with training. So I would not want anyone to come at the diving center with their goggles and say, I want to dive more than 30 meters. That's not it. So even though we do not have any regulation in Malaysia for people to dive leisure, but those providing these services or recreational dive, they do follow. For those who want to just do snorkeling, that's fine. 5 meters, that's okay. But anything beyond 30 meters, that person needs to go for the training to know all the physiological and any consequences of it. Yeah. All right. I think if you go next one, just basically on if there's any treatment needed, initial first aid, make sure it is safe, primary survey, ABC, and then for AGE, next one, Sharif. Specific treatment will be for HBOT. 100% oxygen given immediately, keep the patient horizontal supine to minimize cerebral hypoxia, minimum movement to avoid dislodge, and transport to the nearest medical facility with hyperbaric capability. So if you practice underwater medicine, so you need to know which hospital or which clinic or which center do provide this. But for emergency, for the center we have Lumut under Army, kita punya askar
Navy.
laut dan tentera laut, ya, Navy. Yeah, Navy, and we do have certain practitioner who do keep the HBOT in their clinics. I think Dr. Lichitang, I think practice that as well. Lichitang, yes, yeah, he has a clinic in Ipoh, Green Town, and there's also quite a few practitioners who do have HBOT in their practice. I don't have one, but like I said in the beginning, I only do medical screening for those going for diving. So I have covered 46 minutes. There's quite a bit more of slides, but I think it's more in depth of treatment and medical. For medical screening, I think the most important one would be cardiac, lung function, equilibration, ENT is very important. Of course, psychological. You don't want anybody with suicidal thoughts going for diving. And heart, of course, angina, unstable angina is no. Asthma not treated, no. Hypertension not treated, also no. So medical illnesses, if they can't work on land, let's say severe CKD, chronic kidney disease, of course, this person wouldn't be fit to go for diving as well. So for diving medical, if for commercial, minimum I would do for everyone would be just a step test, or if any clinic do not have, I would basically suggest for that the diver, to go for exercise stress test under cardiologist to make sure their heart and lung function are normal and fit enough for them to go for diving. Like I said, the pressure, the coldness, hypothermia, psychological, are all needing a person to be fitter than us working in the office, obviously. Yeah. All right, with that, I end my talk. I leave it back to Dr. Abid if there's any question for me to answer.
Dr. Hazlee, thank you very much for your very sort of comprehensive coverage on issues with diving and the health risks that they face. And therefore, we have a responsibility to assess them before they go on a professional diving
Yes.
assignment, So that's one part of it. Are there any questions from participants? Let me just check the question section. I can't see it. Anyway, before let me just say, okay, just one question. We have read about the hyperbaric oxygen system being used for non-underwater issues.
Yes.
for healing of chronic ulcers and things like that.
Chronic
Can you
ulcer,
tell?
diabetic. Yes, yes, yes. So, as we know, hyperbaric oxygen therapy, basically we push a lot of oxygen under pressure. So it makes sense that because I've come across quite a few of my patients with diabetic and somehow got
Mm,
injured, and it took a long time for them on natural dressing, normal dressing for them to get healed. And I do refer them to I think this army base here hospital in
mhm.
Wangsa Maju, and they do
Okay,
open it for the public. So if your
I
GP
see.
basically wants to refer a person with that kind of problem, you've done your normal dressing 1 week, 2 weeks, 3 weeks, and still the same or getting worse, it's a good basically practice to refer to HBOT for
Mhm.
the treatment. So one person, I know him personally, working oil and gas, but he keeps seeing me for their offshore, with offshore.
Yeah.
And unfortunately, he basically had a big cut at his leg. And I did the dressing for a few weeks, and his diabetic is not being controlled. HbA1c 7, 6, 8.2,
Mm-mm.
8.3. I told him it's not going to be good if I just do normal dressing. So I
Mm-hmm.
referred him for 20 session. Basically, I refer, but the
Mm-hmm.
center decided to give him 20 session where he went every other day initially,
Mm-hmm.
and
Mm-hmm.
then I think about one or twice per week. So completed the 20 session, and to my surprise, the wound healing is much faster. Of course, before he went to chamber, we do the dressing, and
Mm-hmm.
that will be on the day he's not on chamber, who will on his own doing dressing in nearby clinic, and he basically fully recovered within 3 months. That was my surprise, despite his diabetes is not well controlled. So that is of course few cases that I do had after amputation, re-amputation. Army come to see me basically, and we provide the dressing. And of course, army being an army, they are entitled to treatment at the center. And they came back, despite big wound, big diabetic wound, re-amputation, they fully recovered. Rather than usually people just progress from re-amputation and then ankle and then going to the knee. And I have seen quite a few cases under myself. We managed to basically contain the spread, just re-amputation and fully recovered. So HBOT is not just for recuperation, diving emergencies, but I do believe there are a lot of paper now talking about other than diving emergencies. And because I think the physiology is that higher pressure oxygen given, a lot more oxygen going into that local tissue that's been
Mm-hmm.
exposed because of bleeding or amputation or whatnot. So it just makes sense a lot more oxygen being in that tissue, and it's recover faster. But of course, not just the oxygen therapy, it has to be daily dressing and this laughing on every other day. So the cases that I had in hospital Angkatan Tentera, they do provide dressing as well. So one person, if our practice probably about 10 minutes per person, and with the Navy center, the hospital center, which is run by Navy, they carry out dressing for a person. Big wound can go 30 minutes to 1 hour for per person. Just imagine.
Mm-hmm.
That's how
Yeah.
good it is. So basically, this laughing, they make sure all the tissue become red, a bit of bleeding to make sure there's a lot of granulation tissue, and they
Mm.
heal. They heal. And unlike what we did in the clinic, basically we just do simple dressing and then we close it up again. But they are doing it proper. And I've seen a lot of cases that going there for, I think, on daily basis. If you do have contacts at hospital in Wangsa Maju, they have the session on daily basis
Mm.
for not just decompress, but of course for all other cases that may benefit from HPOT. Thank you, Dr.
Mm-hmm.
Abid, for the question. Yeah.
Well, Dr. Hazlee, another question relating to the hyperbaric chambers again.
Yep, can.
That, of course, some of it you answered already about the centers that offer medical grade treatments. Are there
Yep.
specific requirements for becoming a registered, person to run
Okay.
the equipment?
Not really. In Malaysia, like I said, it's just like any other treatment you want to provide. You can provide
Mm-hmm.
treatment just like cosmetic is not yet very, in a way regulated for this treatment.
Okay.
So, and if you do read enough, there's a smaller chamber which is for the feet. If you
That's
just
right.
look it up, yeah.
Yeah,
So for
I've
those
seen that.
having diabetic foot, it's just up the oxygen that could be pumped only up to your knee or probably up to
Mm,
your thigh maybe. So this kind of treatment is high pressure oxygen given under higher pressure than ATE 180.
mhm.
It's been you can order the machine. You can use it in the clinic. I think not yet regulated at this point. But for recompression, I think that person need to go for level 1 and level 2 underwater medicine training as well as treatment, because you need to understand the protocol.
Yeah.
So a person with 1 cm, 2 cm up in the brain or up in the lung, there is a protocol for it. We need to recompress up to how depth and how slow for us to basically compress again or decompress that person from recompression to a smaller bubble, and how slow, how fast we need to recompress a person. So all that is a table to it. Usually we follow US Navy table for the treatment. I think Lumut also following the same under our Navy Underwater Institute in Lumut. So there's a protocol. So I would not want anyone to today, buy a chamber and start doing treatment. So we wouldn't know head and tail of how to use that
Mm,
machine. There's a protocol to it. So I'm not licensed to treat, and unless if I want to, I will go for level 2 for treatment, where I'll be
mm.
basically attached to a chamber unit under hospital setting where I do the treatment, then I become a licensed practitioner. But
Mhm.
for other purpose other than recompression, I think it's okay if it's small enough. It doesn't involve systemic. I mean, for leg, I think it should be okay. It's not licensed. But for
Mm.
treatment for HPOT, recompression, CAGE, pulmonary barotrauma, I think need to have to go the second level of the training
Mhm.
underwater to give the treatment properly. Thank you, David.
Thank you. There's another question here. It says, how about the requirement for fitness to work in pressurized vessels? Is there a requirement from DOSH on this one?
Okay,
Uh-huh.
you can you can answer if you want to.
Jan, go ahead and answer, please.
All right, okay. So it's not under underwater method, of course, it's under pressure. So
Mm.
usually pressurized vessel is also under confined space. So under
Ask
Dodge,
question.
there's not so much of pressurized vessel because you don't work under pressurized vessel. Basically, all between release, and you will be entering to for maintenance,
Mm.
for shutdown,
No, yeah.
cleaning, or not.
Mm-hmm.
So it's fall under confined space entry,
Three
case
lah.
body system, making sure you assume all the toxic gases if there's any, or gases
Yeah.
if there's any, make sure it's neutral enough for you
Mm-hmm.
to go in and it's safe. So that's under confined space entry under DOSH. For fitness uh, to work under that also um, not so strict, but if I knew the work's going to be physically demanding, I would at least do Chester step and make sure the ECG is normal, lung function is normal. That is part of
Come on.
CSE. And if
Yeah.
abnormal, then I will send for stress test.
Mm.
Chester test that may not be enough. It's not clinical.
Mm.
It's clinical will be sending to cardiologist to clear that person for to work. If it's involved physically demanding and just confined space entry. Hope that answered the question.
I hope so. Anyway,
Yeah.
another question that popped up in my mind was for to put a person to a hyperbaric chamber.
Right.
What are there any contraindications, even though a person needs to be in a hyperbaric chamber, whole person? Is there any
Okay.
contraindications where you say no,
Um,
no, we can't? Yeah.
Right. So if we suspect it's only diving and there's no other complication, then
Mm.
it's okay. But if we suspect there is more to it, there's bleeding in the blood, so it could be contraindicated because you start to
Yeah.
push, and if you are unfortunate enough, the bleeding is going to be more.
More. Yeah.
Especially if, yeah, the person's already come up from cold and you start to give hot when there is bleeding.
Mm-mm.
So it'll be expansion of bubble, a lot more bleeding due to your practice. So it's not so straightforward, but the person who are trained on this would know who can come in to HBOT and who with a lot more complication would need multi discipline treatment. Neurology should be in, physician should be in, as well as underwater
Radiology.
medicine specialist before we allow that person to be treated in.
Okay, good.
In
Thanks
yeah.
so much. Anyway, are there any other questions from listeners? Please type in your question.
So just to add in, any you want to ask question? Sorry.
I'm just checking to see the people who are still on the
Right.
call.
Yeah.
How any more questions? Yeah.
Just want to add in, a lot of time people comes to me for recreational. So tell them anything less than 20 meters, I think should be fine. But I do carry out the medical. I carry out, to see baseline spirometry. I do ECG, make sure they are okay in terms of their psychology and heart, ECG minimum. But the contraindicated one, I think I will go a bit deeper. So the one with asthma, for example, or heart problem, angina, on treatment for heart. I think for this one, I will basically go all out. If I need to refer to cardiologist, I refer to respiratory physician, I would do so and get clearance from them. So we don't want cold induced asthma. We don't want cold induced angina. We don't want all that because of them diving and we missed out on that can cause them into complication, medical complication by we not going to the extent where clearance from physician may be required and cardiologist may be required as well. So bear that in mind. Lung, heart, yes, ENT as well. And previous history of pneumothorax, look into that as well. And cognitive impairment. So we know that person is not well in terms of cognitive and they may not be able to follow the diving table. That's also important. So that, no, I'm okay, I'm a diver, but my daughter autistic or Down syndrome, I just want to bring her along 30 meter. I would say no, because they are not smart enough. Yeah, if the father basically collapse and the daughter wouldn't know how to do, so I wouldn't want anybody with cognitive impairment to go into diving as well. Yeah.
Well, Dr. Hazlee, I think so far there are no other questions. I'd like to, on behalf of AOEM, to thank you very much for your contribution. No, I mean, this is, I think, the first time AOM has doing something on underwater medicine, really. So I think it's important. And so, we are really, really appreciative of your time.
You're welcome. And my pleasure as always.
Right. Okay. Sherry, now we have come to the end of the webinar, but just before you go, just to remind our listeners or our attendees of our 24th Asian Congress on Occupational Health to be held in Kuching, Sarawak, in August of 2026. So if you are interested, we would like to invite you to show some interest in our Congress. You can go to the website and use the QR code to register your interest or to register for the Congress. Yeah. Okay. So that's one part of it. And the second one is we will share with you the QR code for you to, to take note for if you want to claim CPD points. Yeah, this session will give you 1 point at least. Okay. Thank you very much. And so we hope to see you in the next series. Okay, here's the QR code, yeah, for ACOH 2026. Be held in August